So safe and effective oxygen therapy. These are my objectives. So you will be getting involved in prescription, although it's a medical officer's or the consultant or the senior officer's job. You will be getting involved in prescription, administration, and importantly, monitoring in oxygen therapy. So remember this forever. Oxygen is a drug and it is commonly used in anesthesia, critical care, and acute patient management, and it should be prescribed, administered, and monitored. So prescribed, administered, and monitored. So soon, what needs oxygen prescription? So if there's a documented hypoxemia, oxygen should be prescribed to achieve a target saturation of 94 to 98 for most patients who are acutely ill, or 88 to 92 or patient-specific target range, those at risk of hypercapnic respiratory failure. Best practice is to prescribe a target range for all patients at the time of admission so that appropriate oxygen therapy can be started and managed. So make sure when the patient is getting admitted, so you get the medical team to involve and see what range that the patient belongs to, what targets of oxygen that patient needs to be categorized to. So soon this will be implemented when you prescribe oxygen, or the patient will be on oxygen when in the ward. So you need to document everything according to the chart. So the patient's details, what are the oxygen amount of oxygen that patient is receiving, what is the target oxygen saturation that patient should achieve, what sort of a device that's been used to deliver oxygen, and how much oxygen being delivered, whether we are de-escalating or escalating. So get familiarized yourself with the chart. So use the chart appropriately so that you can use the oxygen properly. So when you are using the chart, you need to know about these abbreviations. If the patient is in nasal cannula, use N. If the Venturi mask, depending on the percentage, there will be abbreviations. So yes, now you know how to prescribe the what to do when the oxygen is prescribed. So before prescribing, you need to have an assessment of oxygen, assessment of degree of hypoxia or hypoxemia. It depends on the clinical features, arterial blood gas saturation, or the pulse oximetry as simply. Similarly, when sometimes you are the first contact of the patient, get an idea about the work of breathing of the patient. Depending on the respiratory rate, as Dr. Ranga Gunasekera said, the respiratory rate is one of the most vitals which has not been done properly. So have an idea about the respiratory rate and see whether the patient is having nasal flaring, sternocleidomastoid usage, or abdominal muscle usage. So use of accessory muscles of respiration. So if that is there, escalate this patient to the medical team. Right. So regarding the targets, remember hypoxia as well as hyperoxemia both are having adverse effects. So you should not over-oxygenate the patient as well as you should not under-oxygenate the patient. So all acutely unwell patients without the risk of hypercapnic respiratory failure, target saturation should be 94 to 98. However, keep in mind, elderly, critically ill patients may have different target values. At the same time, patients at risk of hypercapnic respiratory failure, target saturation should be 88 to 92. However, again keep in mind, all the patients with COPD may not fulfill this criteria. They might not have high carbon dioxide values, so they can go up to 94 to 98. Recommendation on oxygen targets aim to achieve normal or near normal oxygen saturation for all acutely ill patients, except those at risk of hypercapnic respiratory failure. Recommended target saturation range for acutely ill patients not at risk of hypercapnic respiratory failure should be 94 to 98. I'm reiterating the point again and again. For COPD patients, yes, a different target value. And most importantly, as Dr. Gunasekera said, when you are following the Muse or use chart, see whether the patient's oxygen saturation is going below more than 3%. If that is so, escalate it to the relevant medical officer or the consultant or whoever the medical team that is involved. Because that shows from that point of patient need escalation of oxygen therapy. Right. Briefly, I want you to have a look at this chart. When you are approaching a patient, don't put on oxygen on every patient. So if the patient is, because hypoxemia and breathlessness are two different things. So all the breathlessness patients cannot be hypoxemic, and vice versa as well. So if the patient's saturation is more than 93%, you don't have to put them on oxygen. So critically ill patients, so let's go through two scenarios. A critically ill patient comes to your ward. If the patient's saturation is less than 85, again, provided that patient is not hypercapnic respiratory failure or COPD patient, put the patient on 15 liters of oxygen on reservoir mask if the patient's saturation is less than 85. Critically ill, saturation is less than 85, you put the patient on reservoir mask with 15 liters and then proceed from there onward. However, if the saturation is bit more than 85, you go ahead with first nasal prongs and assess in 2 to 3 minutes time, put back the face mask and escalate in that ladder. Second thing I want you to remind is patients commit acute stroke and acute myocardial infarctions. Those patients who have saturation is more than 93 or 92, they don't need oxygen because that can increase the ischemic penumbra or the infarction. So all those patients don't put on oxygen. Make sure if their saturation is below 92 only, below 90 only actually, you have to put. Because there's a controversy between 90 to 92, but if it is more than 93, then don't put on oxygen. Right, this is the guideline recommendations. Just wanted you to highlight the fact that I mentioned earlier, breathlessness and hypoxemia. Say for example, patient coming with a neurological conditions, something like Guillain-Barré syndrome or acute respiratory muscle weakness due to some other reason, they are, for us to improve their breathlessness, we need to go for elective ventilation, not the oxygen. So select oxygen carefully when it is needed and go ahead with that. And patients with metabolic and poison patients, they don't always need oxygen. Right, so we talk about prescription and administration, what are the targets and when to administer oxygen. Let's talk something about the oxygen delivery devices. So when to decide and what device to be used will be a medical decision. So the senior doctor or the consultant will decide on that. But several factors are involved in deciding what device to be used. Patient comfortability, level of FiO2, resistance to breathing, level of humidification, availability, and efficient and economical use of oxygen. So oxygen delivery devices, so depending on the FiO2 and the peak flow rate or the flow rate of the oxygen that we need to use for that particular individual patients, will be deciding on the what equipment to be used. So there are low flow oxygen delivery devices and high flow oxygen delivery devices as categorized here. And similarly, there are oxygen devices which we use as fixed performance devices and variable performance devices. These all are depending on what clinical setting that we use these devices. So nasal prongs, as you all know, it delivers 24 to 30% of oxygen, but remember flow rate is 1 to 4 liters. Don't put the patients on oxygen on face mask above 4 liters, because you're not going to achieve anything in addition to what you have already achieved. So what are the advantages of nasal prongs? Patient comfortability, patient eat, talk and cough, right? Disadvantages, above 5 liters, patient will have this discomfort and drying of nasal mucosa. Face mask, 1 step above, minimum flow is 5 liters per minute. So if you're using a face mask, don't use flow rates below 5 liters. So use it at least 5 liters per minute. So it's a simple, lightweight, deliver up to a FiO2 of 60, depending on the flow rate. Roughly, if it is 5 to 6, it's 40%, 6 to 7, 50%, and 7 to 8, about 60%. And so make sure you document these things when you are using face mask. What is the flow rate that you are using? What is the amount of oxygen that you are using? And when it comes to mass of reservoir, there are 2 types. So reservoir bags remains the inflated during the both inspiration and expiration. So when you use the non-rebreathing mask or the mask with the reservoir, make sure that bag is filled with oxygen. If that is not there, so that effect will not bear. So you have to have a reservoir to get the maximum effect of the mask. So priority nursing intervention, set flow rate so mask remains 2/3 of full during the inspiration. Keep reservoir bag free of twist or kinks. If the bag is twisted or kink, then again that effect is lost. So you can deliver up to 95% of oxygen FiO2. So provides the highest concentration of oxygen, even 95 to 100%, depending on how the mask is fixated to the face. Flow rate is at least about 15 liters per minute. Advantage, delivers the highest possible oxygen concentration, suitable for spontaneous breathing patients. Venturi mask, designed with wide bore tubing and various color-coded jet adapters. Each color code corresponds to a precise oxygen concentration and specific oxygen flow. Venturi masks provide an accurate concentration of oxygen regardless of the flow rate. Available in various concentrations, Venturi masks are suitable for patients needing a known oxygen concentration, with certain masks particularly suited for those at risk of carbon dioxide retention. So remember the colors. Of course, they will be labeled the particular percentages as well as the flow rate in separate in each category of Venturi masks. What are the advantages? It delivers most precise oxygen concentration, as I said, and doesn't dry the mucous membrane. Right. Little bit on high flow oxygen therapy, because in the COVID era we have been using this abundantly. High flow nasal cannula are increasingly used as an alternative device for adults and children, including infants and neonates, requiring medium to high concentration of oxygen therapy. Right. So again, these charts will be introduced soon through the National Oxygen Guidelines. So remember the flow rates, percentage of oxygen that you use, how much time that you have been using high flow nasal oxygen, all those things needs to be documented. Arterial blood gas values that has been there at the time of initiation. So those things needs to be included in the chart. If patient, this just to remind you what I have been talking for last few minutes. So you start with 24%, and if the patient is not getting the required target oxygen saturation, you can go up the ladder, go to white, go to yellow, go to red, or go to green, and if that fails, go for the non-rebreathing mask. So you can go up and down depending on whether you are escalating the care or de-escalating the care. So if hypoxemic, initial oxygen therapy is nasal cannula on the other hand, 2 to 6 liters, and increase to go up to a face mask and then to reservoir bag. Little bit about non-invasive ventilation. Can deliver specific FIR to a PEEP pressure support to augment the respiratory efforts. Do not need invasive airway adjuncts or endotracheal tubes. Right. So non-invasive ventilation, CPAP or BiPAP, as you know, those are high pressure devices. One thing that I want to highlight when you are using the face mask for CPAP or BiPAP. Measure the correct length from bridge of the nose to the chin and use the appropriate mask. Otherwise, the effect will be lost. So when you have a very high leakage, so the purpose of delivering through it will be lost. Again, you will have to monitor you chart for NIV and humidification of oxygen, because I have seen many times CPAP or the BiPAP is being used, and even the oxygen is being used without being humidified, right? So consider using humidified oxygen for patients requiring high flow systems for more than 24 hours or experiencing upper airway discomfort to dryness. So other patients will experience severe dryness in their upper respiratory tract and they will have severe discomfort. And in emergency, the humidified oxygen use may be confined to patients with tracheostomy and artificial airway. Again, another take-home point, when you are nebulizing patients while they are on oxygen. So if they are using a face mask, use the nasal fronts if you can't use the oxygen as the driving gas for nebulization. Either you use the nasal fronts at the same time or use the oxygen as the driving gas. So don't stop oxygen just to nebulize the patient, oxygen as the driving gas. So complications of oxygen therapy, drying of mixing membrane, so you can read about toxicity and monitoring. This is one important thing I need to highlight. I have only 45 seconds. Of oxygen therapy is crucial. Nurses in hospital must sign the oxygen chart during each drug round. This ensures the patients are within the target saturation and consideration is made. Patients prescribed an oxygen target rate currently on AR during the drug round should be signed using the code on the drug chart as well as the news chart. So observation chart should be always reflects this one. And after initiating or increasing or decreasing oxygen therapy, patients should have their oxygen saturation observed for at least 5 minutes. If oxygen saturation exceeds the target range, the patient is stable, modify the delivery system or oxygen flow rate to bring the saturation within the target range. Patients with target saturation of 88 to 92 should have blood gases measured 30 to 60 minutes to ensure the carbon dioxide levels are not rising. So, national oxygen guidelines will be implemented soon. As the previous speaker said, there will be a national audit in 5 major centers using indications, delivery method, and prescription of oxygen in acute medical care setting. In summary, oxygen is a commonly used drug and it needs to be monitored. It's instrument for hypoxemia, not breathlessness. Escalation and de-escalation needs a senior review. Understand the practical aspect of oxygen storage, delivery methods, interfaces is essential for healthcare providers to ensure safe and effective oxygen therapy for their patients. Thank you.